Farzad Najam. He's an Executive Director of Center of Excellence for Cardiovascular Health, Director of Cardiac Surgery, Clinical Professor of Surgery at GW Medical Center, which is George Washington University. He specializes in cardiac surgery and has expertise in mitral valve surgery, arrhythmia surgery for atrial fibrillation, circulatory assistance, TAVR, ECMO, and he has numerous publications. He has developed a program at George Washington University, and currently he also has interest in some artificial intelligence, which he owns a company that works with the artificial intelligence, and he can tell us about that after the talk. So his topic today is current state of cardiovascular surgery. Dr. Farzad, please come to the podium.
Well, thank you so much, Saqib, for the kind introduction, and thank you for the kind invitation for me to speak here. Number of familiar faces from the area, from King Edward, many years ago. Almost feels like it was the last century. And it's an honor, a great privilege to be speaking to you about what has happened to cardiac surgery and what was the past and the future. And just wanted to keep this talk very light, very simple. So cardiac surgery has a great, innovative, glorious path. I think I would not be wrong if I called Dr. Michael DePakey as the father of heart surgery. It really resonates with us because he was a son of an immigrant family from Lebanon, and he grew up in Texas. And in the 1920s, as a college student, he was thinking about the roller pumps. And the roller pumps are the basis of heart surgery as it stands. And not only that he was thinking about roller pumps, when he became a heart surgeon, he started talking about, did a lot of aortic surgery in Texas, defined the classes of aortic dissection, did landmark publications on aortic dissection, and incidentally, ironically, at 99 years of age, he was treated for aortic dissection in Texas. And he had open heart surgery for aortic dissection at the age of 99. He is also credited with doing the first open heart circulatory coronary artery bypass grafting. Some people say it was Dr. Sabiston, but he defined the boundaries and the technique of coronary artery bypass grafting. At the same time, in Maryland, at Johns Hopkins, a few miles from here, Dr. Blaylock was working in his lab with a gentleman named Vivian Thomas, and they defined the Blaylock shunt, which became the basis of congenital heart surgery for the blue babies. And this was featured in a great movie, which I would recommend one should watch, is Something the Lord Made. And unfortunately, Vivian Thomas was just a technician, a black man in white America, and he was not given the proper credit for what he defined. And legend has it that he's the one who described and defined the technique of the Blaylock thoracic shunt. Now, I'll take you to Minnesota, at University of Minnesota. In the very early days of cardiac surgery, Dr. Walton Lillehei at University of Minnesota was doing open heart surgery, congenital open heart surgery with cross circulation. So the father or the mother of the child would be used as the heart-lung machine. This is the only operation in heart surgery which has a 200% mortality rate, or could have 200% mortality rate. But it's just fascinating that these guys in the 50s are thinking, in the 40s, are thinking about ways of doing heart surgery, which is unfathomable these days with the litigation and the litigious times we live in. But in Pennsylvania, at Jefferson, Dr. Gibbons was married to one of his scrub nurses. They developed, worked on the heart-lung machine for 20 years and did the first operation at Jefferson in the early 50s. 1953 was an ASD repair, and he created the heart-lung machine, which is the basis of what we do these days. Unfortunately, he did 3 operations with his heart-lung machine, 3 ASD repairs, none of them survived, and he stopped operating after that. So that was the end of his career, but he's, again, we stand on the shoulder of these giants who defined what we do. A few miles from here, Georgetown University, Dr. Hufnagel did the world's first valve implant, which was done in the descending aorta for a patient or for a young person who had aortic insufficiency. So this was a ball cage valve, which was the first heart valve implanted. In the ischemic heart world, the Weinberg procedure. The Weinberg procedure was the basis of coronary revascularization. And Dr. Weinberg came up with this concept that if he took the mammary artery, implanted in the muscle of the heart, and this is a submuscular endocardial operation, that somehow this will allow the coronary blockages to be reperfused. What we did was that this was the basis of, also we did TMRs, and a number of people in this room know what TMR was, and that was the basis, Weinberg procedure was the basis of that. Now in Ohio, Rene Favaloro came from Argentina, and he was working in the lab, and he came up with this idea that, we're doing bypasses with these vein grafts. How about using the mammary artery? It's in the chest, it's, open the endothoracic fascia, it's right there. So he started harvesting in situ mammary arteries and started doing mammary artery bypasses in the lab, and that became the focus of the publication, which Dr. Lytle and Dr. Cosgrove published with Dr. Favaloro in the 70s, that mammary artery patency rates are greater than saphenous vein grafts. And he's credited, unfortunately, he went back to Argentina, and in the late 70s ended up committing suicide, and that was the end of his career. So bypass surgery in the 70s really became the focus of treating ischemic heart disease. Ischemic heart disease, it erupted, and by some accounts, in the United States, there are about 400,000 coronary artery bypass grafts which are done every year. That led to also eruption and the advent of endovascular treatments with balloons, bare metal stents, and drug-eluting stents. Now we're dealing with 3rd or 4th generation of drug-eluting stents, and that was a pivotal point where cardiac surgeons and cardiologists started creating silos. So we were working together, and now then the silos got created. What's better? Do we operate on these patients, or do we take these patients to the cath lab and fix it? Do we do a balloon? Do we put a bare metal stent? Or put a new generation of stents which started coming about in the late 90s. I was present in many cath labs where arguments between the surgeons and the cardiac surgeons were crazy, that finger pointing, that this is better, this is crazy. So multiple trials were performed. Syntax trial was one of the trials which compared drug-eluting stents, interventional PCI with cardiac surgery, and the higher the Syntax score, the better heart surgery we did. The lower the Syntax score, the PCI did well. Well, anyways, the focus of this talk is not to get into a debate of what's better, but I just wanted to show you that many trials were done to try to answer the question, what is better? And that became almost like a binary conversation in the late 90s, early 2010 to 2022, in whether in diabetic patients, are we better off who have multivessel disease? Do they need coronary artery bypass grafting? Or can we perform multivessel revascularization? And what came about was that if the diabetics have multivessel coronary artery disease, some of the death rates were higher, but the target vessel revascularization or reintervention rates were higher in patients who had PCI performed. So many, again, with the newer, the second to third generation drug-eluting stents, the gap was closed with heart surgery. The gap, if you extrapolate and let these curves go on for 20 plus years, there is a closure of the gaps, and financially, economically, there was an equipoise between heart surgery and PCI. And also, some of the newer trials compared left main stenting with coronary artery bypass grafting, and very favorable results even with PCI versus coronary artery bypass grafting. So in this spectrum, you can see physiologically, if the syntax score goes up, there's technically difficult to intervene on these patients. There was more favor in terms of coronary artery bypass grafting. With the lower syntax scores, it was kind of equal. The strokes were higher in coronary artery bypass grafting, the MI rates were higher in PCI. So we came to the conclusion, the creation of the heart team, that we can we achieve complete revascularization? That was a question we started asking. Instead of pointing fingers at each other, like what's better, can we achieve complete revascularization? What is the short-term risk of what modality do we offer our patients? Is coronary artery bypass grafting is going to have a higher rate of stroke or versus the reduced rate of target vessel revascularization? And eventually, what are the patient's preferences? I've never said to a patient that, okay, you know what, if you don't do bypass surgery, you're going to die. Patient preferences are really important in terms of whether we perform bypass surgery or PCI or a hybrid thereof. And these patient preferences have to be taken into consideration, as nowadays we have a shared decision-making paradigm. So again, the whole concept we're still debating in cardiac surgery. Is PCI better, CABG better? PCI better, CABG better? And there are many factors that one has to understand what is the algorithm defining what is the solution for that. That leads to the valvular heart disease. As I showed you, Dr. Hufnagel did the first heart valve operation, putting a ball cage valve in the descending aorta for a patient with aortic insufficiency. In the last 40-50 years of heart surgery, we've had an eruption of the devices that we have. I'm implanting the 6th generation valves that we are implanting now. We started with the caged ball valve, tilting disc. We had single leaflet valve, we had bi-leaflet valve, we had the bioprosthetic valves. The bioprosthetic valves are the porcine valves. Nowadays, all these companies have different valves. I'm just showing you this, some samples. Abbott Medical has their EPIC valve, which is based on the platform, which is a porcine platform. Porcine platforms generally used to have a higher structural valve deterioration rates. They also have mechanical valves. Mechanical valves have their own issues, whether to take warfarin or not to take warfarin. Some of these valves have been trialed on patients who can take NOACs, and can they hold up for that anticoagulation. Some trials were stopped at an earlier stage that NOACs were not good for the mechanical valves. Medtronic has its own valve. I've implanted all of these valves. There's on the right side of your screen, you have a stentless valve, which is great hemodynamics, but higher rates of structural valve deterioration. Their platform, Medtronic has a platform which is porcine, and it's not bovine. Edward Life Sciences came up with a great platform, which is all bovine platform. And the last generation, the 6th generation platform, is the Resilia tissue, which is unbelievable tissue bioengineering, which abolishes all these calcium binding sites, which we believe is the reason for structural valve deterioration. Then mitral valve repair. We didn't understand what mitral valve was. What did mitral valve really do? And we learned from pioneers of heart surgery, Denton Cooley, how we do mitral valve repair. Dr. Carpentier came to Texas to see him how to do a mitral valve repair, and he said he took a mitral valve out and put a new heart valve in, and he said, this is how we repaired the mitral valve in America. And that was in the 70s. Mitral valve repair techniques have erupted. We do know that repairs are better than replacement, and they are beneficial in terms of lack of anticoagulation, longevity, lack of prosthetic valve endocarditis, and the impact on the ventricular anatomy. What does ventricular anatomy do if we repair the mitral valve? And that's why, if there is a person who's got myxomatous disease and he doesn't even have symptoms, it becomes a class 1B indication to send them to a center for mitral valve repair. So mitral valve repair for a classic P2 flail or myxomatous valve is really the standard of care. But there are many techniques that have evolved over the last 20, 25 years, from quadrangular resection to sliding valvuloplasty to haircut procedure to enhancing the posterior leaflet. So that field has exploded. Now shifting gears, we talked about the valvular heart surgery. What happened in the early 2000s? Alain Crebier in Paris came up with this idea that if we can implant a valve through a person's groin, now we changed the paradigm completely. We're now shifting from open heart surgery to how do we implant the valves. And if the valve can be crimped down that it could fit a catheter, we can implant a valve. And what are the sutures which are holding these valves in place? It's the patient's own calcification. There are no sutures. And then the field of this erupted. The first trial that was done in the United States to compare patients who were not surgical candidates to this therapy. It was a landmark trial which led to FDA approval of these therapies and showed that there was a marked difference in survival of patients who were not surgical candidates and who were offered transfemoral or transapical aortic valve implantation. Partner 2 trial was a sequential trial which was secondary to compare patients who are intermediate risk. You don't have to be high risk or not a surgical candidate. And what this trial showed that TAVR is not inferior. It was a non-inferiority trial. It's not inferior to surgical aortic valve replacement. And then partner 3 trial was done as a trial in patients who were low risk for surgery. And again, it showed that this was the modality, the treatment arm was not inferior to surgery. Nowadays, in the world of heart surgery and structural valve, we have a number of valves available from SAPIEN 3 Ultra to SAPIEN 4 Ultra, which have reduced the level of paravalvular leak. And then there is other valves which are balloon expandable or self-expanding valves, and the Evolute, the Navitor, and there are hundreds of valves available to the cardiologist and the cardiac surgeon. So with the structural valve team formation and TAVR or TAVI, there was another shift in paradigm. How do we treat aortic valve disease as heart surgeons? And we had silos, so there were silos of cardiac surgeons and cardiologists. Now we were brought together because of this technology as a heart team model. And the heart team model not only includes the interventional cardiologist or the cardiac surgeon, but it includes the imaging cardiologist as well. So the concept of the heart team is very important. It's not one person who makes the decision. That was democratization of the decision making, which is important for treatment of these patients. So there was another paradigm shift that how do we treat these patients. You know, we talk about patient prosthesis mismatch all the time. Is that really an entity? We don't know, but multiple publications. And when the cardiologists started believing in patient prosthesis mismatch, a little bit of our life became difficult because now we cannot implant smaller valves or relatively smaller valves. So now we have to extend the operation to a bigger operation, which requires root enlargement to put bigger valves, because God forbid if you put a 21 millimeter valve, you'll be cursed out by your cardiologist. So that's another change in the paradigm. It became shared decision making between the cardiologist and cardiac surgeon and the patient in the center of this decision making. That's another shift in the paradigm that happened in the late 2000s. And now, what is the lifetime management? We'd never heard of these terms. What is the lifetime management of a person who shows up at your doors with aortic valve stenosis? Is it 60 years old, a 50-year-old person, or a 70-year-old person? Is going to be SAVR going to be the first operation they get, or TAVR they get a first operation? What are the patient preferences? What valve are you going to implant in these patients? I mean, Resilia platform is an expandable platform that these valves can be expanded with a balloon. It's a breakable valve. So there are a number of shifts in the discussions that we had with patients that there's data out there. You know, if you replace a bioprosthetic valve in a patient, the mortality is high. Recent publication, replacing valves in patients who've had TAVR, mortality is high. So how do we incorporate all the data that is being thrown at us into these discussions with the patients with a shift in our discussion and the data points? Mitral valve repair. Now we came to this concept, which was created by a surgeon in Italy, the Alfieri stitch. It's a simple operation, requires open heart surgery, that you join the anterior leaflet and the posterior leaflet with a stitch and create a single barrel mitral valve into a double barrel mitral valve. Quick operation, recurrence of mitral regurgitation was higher if these patients didn't have annuloplasty. That was the basis of the transcatheter edge-to-edge repair, which was made into the MitraClip. And the landmark trial, which was published a few years ago, was a COAPT trial for patients who had functional mitral regurgitation who didn't do well with surgery. I mean, there was a publication came out of UPenn where if we repaired these valves, there was a higher rate of recurrence of mitral regurgitation. So this landmark paper with COAPT trial really changed the paradigm in how we treat patients with functional mitral regurgitation. Explosion in the mechanical support that we provide. I'm focusing right now on the temporary support devices that we have. On the left side, you have an Impella 3CP. On the right side, you have an Impella 5.5. And these are devices which are now available to us to support the right ventricle and even the left ventricle. The bigger devices, the concept is based on the Archimedes screw. And these devices unload the heart, and they can be implanted percutaneously or can be implanted with a surgical cut down for the bigger devices. And then also in the early 2000s, the percutaneous PVAD, which was used quite frequently in some centers, which became very comfortable with the transseptal puncture, and that also led to reduced mortality. For the right ventricular support, a percutaneous support device like the Protect Duo RVAD, it is like a Swan-Ganz catheter, sits in the pulmonary artery and provides beautiful, great unloading of the right ventricle. So the whole concept, we were like, why do we do mechanical support on these patients? Because it reduces the myocardial oxygen consumption, and that leads to better outcomes on patients who are supported with temporary devices. And then the ECMO in the 70s, we wanted to bring the heart-lung machine. As you can see on the left side of the slide, heart-lung machine is a massive device. It's got a lot of pumps, number of tubes that come out, and we've made this into a small the first ECMO patient on the top of the screen, this is a young kid who had trauma and needed VV ECMO secondary to ARDS, and this is the ECMO circuits of the 70s. Now, this is a small ECMO circuit that we actually jerry-rigged in our institution so that the nurses, the ICU nurses could handle it. You don't need a perfusionist to do this. So then, from the temporary devices to the implantable devices, we've gone through transition of implantable devices. I was fortunate enough or unfortunate enough to implant those pneumatic pumps which used to sit outside the patient's body, and you could close the chest, but they were pneumatic pumps, used to make a lot of noise, they had their own problems, to these implantable pumps from the HeartMate 1, HeartMate 2, and now HeartMate 3. These pumps allow the patients to live a normal life, and they have to, of course, the driveline infection continues to be a big issue with these patients. The progress that we have attained in aortic surgery has been unbelievable. From the time that Dr. DeBakey described aortic surgery to times what we can do nowadays with the aortic aneurysms and aortic root aneurysms is unbelievable. From the David procedure to the Yakub procedure to the Florida sleeve, we have 5 or 6 procedures that nowadays a heart surgeon can perform to fix these issues. So when I decided to become a heart surgeon more than 2 decades ago, I was told heart surgery is dead. Is it? Does this patient have a pulse, or is it really dead? And I don't think so. I think from my experience and experience of many heart surgeons, that we have morphed into something else. We have evolved as well. We are not the heart surgeons of the 70s or 80s, that this is the only way you do things, and you stay here and I stay here. There's been a shift. I've become a catheter trained physician as well. Of course, my cath skills are not as good as some of the other physicians do, but we have morphed into, we've learned our lessons from the PCI times, and we applied those lessons to the structural heart program. Some of the cath labs, newer cath labs, as like even in Columbia, the director of the cath lab is a heart surgeon. So there has been a shift. So is heart surgery really dead? I don't think so. Heart surgery has evolved into something from where it was 80 years ago, 50 years ago, 40 years ago, to something new. Now, the other question the students ask me, the GW students, the residents, shall I spend that long a time in training? Do I need to spend 11 years? I'll train 11 years to become a heart surgeon. Do I need to spend 11 years training? And I don't really have a good answer. I think hopefully with technology, we won't have to spend 11 years training to be a heart surgeon. There are new things, new technology is coming about that will shorten the length of the learning curve and flatten the learning curve. Our learning curve was very, very steep when we were learning. So what is the future? Where do we go from here? And is robotic surgery the future? Robotic surgery really made open heart surgery minimally invasive. Does it have a future? How do we make LVADs more sustainable without anticoagulation and the risk of driveline infection? Is there a way that we can do wireless transcutaneous energy transfer for LVADs like our iPhones? We put our iPhones, we don't plug our iPhones anymore. Is that a possibility? Is that down the line? Is it in the pipeline? TriClip, this was recently approved by the FDA for a tricuspid valve. Tricuspid valve repairs are the easiest operation we can do as a heart surgeon, but these are the most difficult patients, sickest patients out there, because they get referred at a very, very, very late stage of the game. So TriClip is going to become a reality. Percutaneous mitral valve replacement. There are certain devices that are being tried. Are they going to become a reality in the future? And is artificial intelligence, how do we incorporate, everybody's talking about artificial intelligence. How do we incorporate artificial intelligence? How do we make artificial intelligence help us make decisions? When a patient comes to you with so many questions, some of the times when they ask questions, sometimes I don't have answers because there's so much data out there. Is artificial intelligence going to help us define and describe an algorithm that we can give to our patient that you've got this risk and we can look in the future what's going to happen to you? And then this idea of training surgeons, training interventional cardiologists, we don't have any training simulators like the airline industry. Airline industry requires you to have a certain thousand number of hours before you sit in that cockpit, a pilot sits in the cockpit. And that was we have hashed that out, that the more years of experience you have under your belt, the shorter the cross clamp times, the shorter the pump runs, and the better the outcomes. So based on that, with virtual reality, artificial intelligence, can we do this artificial virtual reality operating rooms that you can go in, practice your skills, and practice on a real patient on whom you're going to operate or intervene, then practice your skills on their virtual model before you actually do it. We stumble upon things. We stumble on the curveballs that are thrown, the zingers that are thrown. Can we avoid to improve the patient outcomes? So that's why this is what the state of the heart surgery is. Where we're going with this, it's anyone's guess, but I think we have a great future. Well, thank you so much.